Hello, I'm Sue. Welcome to Fireside Chat. I'm joined with two very special guests, my co-host Chris Chanko and Charles Gaba. Thank you very much for coming to talk with us tonight. We want to talk about the Affordable Care Act and some changes that are going on. And I think it's going to be perfect timing, actually, to just talk about things as they're developing, right? So how did you get into kind of caring about the ACA?
Sure. Well, first of all, thank you for having me on the show.
Thank you.
Appreciate it. So I was actually a website developer, freelance web developer back in the early 2000s. And but I also happen to be kind of a data hound, just really fascinated by just data, numbers, spreadsheets, and that sort of thing.
Mm-hmm.
And so back in the fall of 2013, folks who may recall that the Affordable Care Act had been a very contentious multi-year battle in Congress and the White House, and it had sort of sucked up a lot of the political oxygen nationally for a long time. And so it finally passed. It was signed into law by President Obama at the time.
Mm-hmm.
And some of the provisions went into effect back as early as 2010, but for it was mostly nominal stuff. The bulk of it didn't go into effect until January of 2014. And the biggest part of that was the healthcare exchanges, as they were called, basically the websites, the online shopping carts for people to enroll in private health insurance through the individual market. And this is the individual market. That's for people who do not have health care through their employer or through Medicare, Medicaid, or other public programs. And so it's mostly people who are either self-employed, as my wife and I were and are, as well as people who work for an employer who does not provide health care coverage, which is mostly small employees of small businesses. And so the websites, there were multiple sites. The biggest one is the federal exchange, which is healthcare.gov, which covers most states. But there were also about a dozen or so states that operate their own websites for their state specifically.
Okay.
And as people may recall, the launch of those websites, people could start signing up for coverage as early as October 1st of 2013. So they had a couple of months to go in and sign up and enroll and pick and choose and so on. And again, it was infamously a technical disaster. The federal exchange healthcare.gov, it crashed immediately.
Oh my God!
Had a massive surge of traffic right away, and it crashed almost immediately. There were technical problems, headaches.
That must have been such a mess.
Yeah, it was.
And unfortunately,
awful.
it doesn't reflect well on going to all this trouble to create something.
Exactly. And after everything that everyone's gone through and all the fuss and bother, it was very embarrassing. And again, as a data guy, I was like, well, after everything that happened, it would be nice to know if people are actually, using this thing.
Absolutely.
And at the time, I assumed that the federal government would be posting a lot of data about it, but they really weren't at first, partly because because of the technical problems they didn't know, and partly because they were so busy scrambling to fix it. But also I figured that the news, the major news media
Of course.
Would be all over this because it was the biggest story in the country at the time. And for the most part, I found that they really weren't. And so I decided to do it myself. And so it started out just sort of a crowdsourcing hobby, just sort of a nerd hobby thing.
Mm-hmm.
And one thing led to another. They eventually came in and fixed most of the technical problems, got things working pretty smoothly.
Wow.
And but in the meantime, what had happened is healthcare reporters and journalists and researchers and such, they were desperate for data, desperate to know what was going on with this new law.
Absolutely. As you can imagine, of course they would be.
Sure. And they didn't have anywhere else to get it from. So they found what I was doing, and all of a sudden, they said, hey, this guy seems to be tracking it. And it just sort of went from there.
Wow.
And as a result, what was supposed to be a 6-month nerd hobby ended up, this is what I've been doing for 11 years now.
That's unbelievable. I'm really glad that you cared, because it's really valuable information, isn't it?
It is. Thank you.
So, unfortunately, I think there's going to be less information available probably going forward, right, about things?
Yeah, well, like I said, I originally started this just to see, how many people are signing up, and that was pretty much it. over the years, however, I've learned from a lot of very intelligent, very educated, very experienced, qualified professionals about how the health insurance industry works, how the healthcare system works, or doesn't in a lot of cases.
Right.
And so I sort of expanded my repertoire to cover not just the ACA, but also Medicaid and small business insurance and group insurance and that sort of thing. And yeah, there's a mountain of data out there, and a lot of it is very vital for policy changes, for budgetary changes, for discussion and debate about future policies, about what we should and shouldn't do, what's working, what isn't working. And sadly, over the last few days, and today in particular, the new Trump administration has apparently dedicated itself to stripping away a lot of that data at least from the public view. I know that earlier today, several databases related to on the CDC's, Center for Disease Control's website, related to data about and research about the LGBTQ community.
Wow.
Has been stripped away. Black maternal mortality, for example, is a good example of something where this has been a problem for years, where black women who are pregnant are seeing a much disproportionately higher mortality rate for their pregnancies, and you need data for that. And if you take away the data, then it makes it much more difficult to figure out why and how to improve the situation. So yeah, there was actually I had been told that there were federal employees who were saying that supposedly some of the federal healthcare related websites were going to be actually taken offline at 5 p.m. today if they hadn't complied with stripping away some of the mandated information. Mm-hmm. I don't know whether that's actually happened or not, but I do know that a lot of the data there is data that was there a few days ago that is no longer available. Because I've checked, I've sort of gone into the CDC's website, the Centers for Medicare and Medicaid Services website.
Wow.
And there are reports and data that they were listed a few days ago, and now they're just. I don't know if they've actually been deleted, or if they've just been taken offline, or just the links have been removed. It's hard to say in some cases.
Right. So Charles, on that line, as data becomes less available, on these websites, right, and let's say it stays offline at least for the near term, are there major organizations, major groups, profit or nonprofit, that let's say rely on that data or use that data somewhat heavily, who would be in a position to push back? And so that's really my question: is who's going to push back against this, taking offline of information?
Absolutely, yeah. There actually have been some researchers and like universities and think tanks and such, around the country who have, in some cases, they've actually been quietly archiving or basically downloading and archiving and mirroring as much of this data as they can on their own servers or on third-party servers or what have you. I myself, I did a sort of a surface level download of as much of the CMS and CDC websites as I could. I don't have the tools or resources to get the actual databases, but at least things like the forward, the public-facing pages that I use. So I've kind of exported a lot of that, and so there have been a lot of think tanks and university researchers and such who have been working on that, and some of them have actually been collaborating. But I'm sure they're crying bloody murder over this. But and there are other resources. Obviously, all of the states, all 50 states plus DC and Puerto Rico and the various territories, they have their own HHS departments and their own data and such. But none of that is going to be as comprehensive. Compiling the data in a comprehensive and easily digestible way is difficult, even when you have access to all of it.
Right.
When the federal government, takes it offline, you lose the ability, and so now you have to, if you're trying to figure something out, you have to patch together bits and pieces here and there, and you might get most of it, you might get some of it.
Right. Right. Do you foresee any legal actions in order to force them to put some of the stuff back online?
I mean, I know that there have already been a bunch of lawsuits filed over other issues, over over the shutdown of federal funding to various grants and programs.
That's right. Yep.
In fact, just a couple of hours ago, there was a second federal judge out of Rhode Island, that issued that basically put the kibosh on one of the executive orders that he issued. I'm not sure which one. So yeah, I'm sure that there are lawsuits being filed, even as we speak.
I would hope so.
The question is, but again, here's the thing: if someone deletes, a database,
then it's gone,
and I mean, you may be able to retrieve it, but maybe not so much, or maybe it won't be so easy to, or maybe it'll be corrupted.
Agreed. Agreed. So it is what it is.
So you can issue, you can pass a law, you can have an injunction, what have you. But if it's gone, it's gone.
Right.
So hopefully that's not the case. But
okay,
I really don't know.
All right. Appreciate
Feels like
that.
a different world, doesn't it?
It is a very different world. Yep.
It's kind of like like the term like something going dark. It sort of feels like that like information, like that data is going dark. So whether or not it's gone, we don't know.
Right.
But it's inaccessible, and it makes you feel like it's gone. Right? The average person who's not a data hound, I'd be like, oh, I can't look that up anymore. Oh well, right?
Yeah, and I mean, it's important, to keep in mind that most people are not, busily scouring the HA Health and Human Services, department website on a daily basis or anything, but when they see a news story that talks about, oh, this many people are uninsured this year, and that's up or down from last year. Well, where does that data come from?
That's right.
Presumably it comes from a spokesperson for the federal government, and so now, do you know, is that accurate? Is it inaccurate? Is it mostly accurate? Who knows? And if you don't have access to that, then then it's kind of a crapshoot.
It really is. Do you want to have a look at like maybe one of the pages like off your website? So acasignups.net is how you can call that up.
Sure.
And then you can, there's stories that you've kind of like put there. So this is really recent.
Yeah. I mean, the very head story is about exactly this. And actually, if you click on that, it'll actually give you just a few examples of on that first headline there.
Okay.
The memory hole.
Here.
Yeah, right.
Yeah.
Yep. Yeah,
Click
right
on
there.
that, right?
Mm-hmm. Yeah, and if you scroll down, you have to actually.
I have to scroll down.
Well, no, if you click on the.
Yeah.
There you go.
There it is.
Yeah, and if you just scroll down there, and this is just from earlier today, and you'll see examples of the Center for Disease Control's Youth Risk Behavior Survey has monitored the well-being of America's high school students since 1991, and for the last decade or so, it's been a vital source of data on LGBTQ youth, and apparently that's been taken offline.
As of this morning, it's gone.
Yeah.
It's just unbelievable. The repercussions are huge.
Yeah, and there are other examples as well, and talking about how that there are students at various universities that are being instructed to go in and download as much, export as much data as they can. Again, I don't know whether it's going to be limited to this particular subtopic, but
we're just reacting to what the changes have been today versus a couple days ago. Right?
Exactly, and and even if it is, that would be awful anyway. But
look at all these archives. My God, Charles, look at this. That's incredible. It's just. Yeah,
you
like
got 11
years. Yeah. There was a really interesting graphic there with the donut there. How do I get there?
Sure, yeah. If you go all the way back to the top.
Okay.
And if you go all the way to the home, go back to the home page.
Okay.
Just click on home there. Yeah, if you scroll down. Yeah, if you just scroll on down again.
Okay.
And you should get to.
So it's way at the bottom, right?
A little bit past that.
So there's
going.
still like ACA is being
you go.
enrolled as far as we know, right? Oh, they're the
Yes,
psychedelic
and
donut
yeah,
returns.
and actually, if you click on
I'll
the
click
headline,
on that. All right.
and again, just scroll all the way to the bottom.
Okay.
and
Yeah,
it'll
no
get you to
problem. That's all
it'll
right.
get you
I'm just
past
glad
all
that
of
we
it. Sure,
can look at it on screen together.
Sure.
Like, this is great.
sure.
I'm going to go kind of fast. I'm sorry.
Yeah, no, that's fine. Yeah, there you go. So what this is, and I just updated this just this week. This is basically, to the best of my ability, it is a graphic a chart that breaks out the type of healthcare coverage of the entire U.S. population.
Wow.
So there's around roughly 340 million people in the U.S., give or take, and it's basically just a color-coded breakout. On the right side, you've got in green, you've got the group market or employer-based coverage,
Okay.
which is maybe 40% or so of the population is covered through their, through who they work for. That also includes public employees, federal employees,
true, yeah.
state, local, the military, which is covered through the Veterans Administration or TRICARE. Along the bottom in orange, you've got Medicare, which again it's a semi single payer program. Mostly for senior citizens, basically 65 and up. Although there are several million people enrolled in Medicare who are under 65. If they have, there's a handful of very specific medical conditions that qualify for you if you're under 65, like if you have ALS, Lou Gehrig's disease,
That's right.
end-stage renal failure, or if you've been collecting Social Security disability insurance for at least 2 years. So that's Medicare. On the left in red or burgundy, that's Medicaid, which is actually administered by the states, but it's mostly federally funded. So Medicaid is funded. It's roughly 2/3 through the federal government, about 1/3 from the states, although that varies depending on the state. And that's primarily for lower income folks. As well as the people who are disabled, who have other types of disabilities, children, and so forth. But it's primarily for lower income people. The yellow slice in the top left, that's the Affordable Care Act individual market.
Okay.
Basically, people who sign up through healthcare.gov or the other state exchanges. And that's this year it's around 24 million people, give or take, which is the highest in history.
Wow.
24 million. Yeah, substantial.
You've got a few, those tiny little slivers in gray or beige. And that's just a hodgepodge of oddball, smaller programs, basically non-ACA compliant policies for the most part. You also have university plans for college students are in there as well. And then you've got the white sections at the top, which is the uninsured population, which is still around 27 million Americans do not have any sort of healthcare coverage whatsoever. It's basically emergency room care, which is essentially they either pay out of pocket, and if they can't afford that, then basically they wait until they're sick enough that they have to go to the emergency room, and then they get treated that way, which of course is not really
goodness.
not really healthcare coverage. So
There's still millions of people who are uninsured, even with the ACA.
yeah, before it's been cut in half roughly.
I was just going to say, if you look at the white roughly plus the yellow versus just the yellow, it's about cut in half.
Yeah, I mean, obviously the population has grown over that time as well, but yeah, at the time the ACA was passed, it was I believe something like 45 to 50 million, something like that.
Okay.
And now it's at around 25, 26 million.
Yeah.
Again, it's still too high.
Huge progress, tremendous progress.
Yeah.
But that section of white is still way, way too high.
Yeah. So now, one thing that's noteworthy about that though is, and you notice each of these sections is sort of subdivided in smaller slices. You'll note, so the uninsured population. One thing that's worth noting is that it's around 26 million people or so. Of that, a big chunk of that, I think it's around maybe half or so, around 14 million or so of that are people who actually are eligible for either Medicaid, the Children's Health Insurance Program, or CHIP, or for subsidized ACA coverage.
Okay.
So about half the uninsured population legally is eligible to have, affordable healthcare coverage, but just haven't signed up for a variety of reasons. And in some cases, it may be that they're not aware of it, that they don't know that they're eligible. They may be misinformed about it. In some states, for Medicaid in particular, there are some states that are friendlier to Medicaid than others. So, there's some states where where the state government openly encourages people, they ad campaigns and education campaigns to, hey, you might be eligible. There are others where they make you jump through a lot of hoops.
Sure.
So there's a variety of reasons. There's also still, unfortunately, especially for Medicaid, there's a stigma that's always been attached to it. There are people who don't want to admit that they need help, for example.
Yeah.
In some cases, there may be a language barrier, obviously.
Sure.
That's
that
very
sort of
true.
thing.
Sure. Which is terribly unfortunate, because this is simply government provided, government subsidized, right? Health insurance, which is there for a reason, and the government wants you to sign up for this, use it,
Right?
100%. And so there absolutely should be no feeling bad about using it or stigmatization about that. It's terribly unfortunate.
Yeah, and I'll also, on that note about subsidization, there's something else that I should note. There's a common misconception that a lot of people have that Medicare, that public health insurance is somehow mooching off the government or something like that. That you're whereas employer coverage is, you're pulling yourself by your own bootstrap. Nonsense. Just about everyone with health insurance in the United States is subsidized by the federal or state government to some degree. Federal, if you're covered, if you have an employer-based health insurance, you are actually receiving tax credits that way. Now, it's not official, but it's basically a tax exemption.
Okay.
It's a payroll tax deduction, essentially.
So that's where it shows up.
Yes, because, and this is something that actually came about. This is actually the main reason why the U.S. has such a weird healthcare system. A big part of it is that as I understand it, I may be wrong on some of the details here, but as I understand it, during World War II, there was a pay freeze that was put into place.
Okay.
And so what a lot of companies did was, since they couldn't, when they wanted to hire to entice new employees, since they couldn't pay them more, what they did was said, well, we'll cover your healthcare coverage. So they started offering healthcare benefits through the employer, And because healthcare coverage through your employer, it's not counted as your official taxable compensation. So that basically you're not being taxed on it, essentially.
Right.
So you get a $50,000 salary plus a $10,000 healthcare policy for your family.
Right.
Well, you're getting $60,000 in compensation, but you're only being taxed on $50,000 of it.
Gotcha.
So the employee gets a tax break, the employer also gets a tax break, and so that's how it sort of stuck that way, and for the last 70 years or whatever. But yeah, so there was actually a study that just came out a couple weeks ago, and I plan on writing a blog post about this soon. Yes. Where they actually, on average, I think it's something like $2,500 a year per enrollee. Is the average, federal tax deduction that you're getting through the people who have employer coverage. It varies widely, but that's the average, I guess. So
okay, nice.
So, yeah. So anyone who says, "Oh, well, I should feel superior because I have healthcare through my employer, I'm not sponging off the government." Yeah. Everybody is, and that's not something to be ashamed of. It's just
absolutely not.
That's the point of it.
This is exactly why the government is there, and really at all levels, right? At the local city level, at the state level, and then at the federal level. This is how we work together at scale, because we know everyone needs it. Let's just be honest. Every person, really cradle to grave, needs health coverage, full health coverage, and so what better way to address it than all of us working together as a community? That's just another name for the government. Right.
Yeah, and I think people when you're driving when you're driving around, not most roads are not toll roads. You're not
right.
paying a specific
Who's
amount
paying
to
for that?
drive. when you drive
Yeah.
your kid to school,
You're not going on a toll road.
yeah, do you feel like you're sponging off the government because you're
Of course
driving
not.
on a? Well, no, your taxes pay for it.
Right.
As they
You
should
know,
be.
right.
The
That's-
roads, the libraries, the public education,
The sidewalks, the street
the
lights, yeah, et
public
cetera.
safety,
Exactly.
the fire, the
Oh,
EMS,
yeah.
the public
Right.
safety.
Worth it.
All of us together chip in because we all need that,
Right.
and that's the way it's supposed to be. And I'll just make one sort of addition to that. For many years, the whole idea of taxation, and this is absolutely intentional by our government. The idea of taxes are bad. Taxes are a terrible thing. It's always better for you to have that money in your pocket than to give it to the government. This is asinine. That idea is just a complete lie, because there are some things, again, that the government at all those various levels that we talked about needs to do, because you can't hire your private police force or your private
Most of us can't.
fire fire and EMS. That makes no sense. These have to be public services, right? And so that's exactly where our hard-earned tax dollars should be going.
Right.
And we should be happy. We should be happy to pay taxes for those high-quality services that all of us use every day, and then enjoy driving on the roads, enjoy the libraries, enjoy the public safety, because we're paying for all of that.
Right.
That's just the way it is. So this whole idea that taxes are always bad, well, who says that? Let's be honest. The wealthy, the rich always say that, right? And it's just a matter of, we've been lied to for so long, a lot of people have bought into that, and we really need to change that mindset.
Well, yeah, I mean, that's, you can argue that a specific tax for a specific, service or whatever, or to a specific population should be higher, should be lower, whatever. But what you're talking about is the general, the big picture, the general
That's
concept
right.
of taxes as a whole. Yes, there are some taxes which should be lower. There are some taxes which should be higher. There should be, and there are some services which, the government is better at handling. There are some services the
Of
private
course.
sector is better. And you can argue back and forth about which of those, is which. But the general concept of, you're going to pay one way or the other. You may pay more one way versus the other for this versus that. But, there ain't no such thing as a free lunch, and so it's like, I mean, even insurance itself, the whole concept of insurance is literally shared, shared risk.
Right. Right.
You're paying into a pool.
That's right.
It's,
It's pool your money, and you tend not to use it when you're healthy.
Right.
When you're sick, you do use it, right? And so overall, the entire community benefits from that.
And it works.
And so you have to pool your money at various times for various reasons. Of course you do.
And actually that now one thing that I think on this sort of same theme, I think one thing that tends to trip people up is that with healthcare, if you're healthy today, most people tend to think that, I'm just, and this is true of any sort of insurance. They think, well, why am I spending, hundreds of dollars per month or whatever when I'm healthy? I don't, I don't smoke. I don't, et cetera, et cetera. I'm low risk, whatever. That why should I be paying all this? And as opposed to, let's say, the roads that we just talked about, where most people tend to drive here and there or get driven.
All the time.
They tend to be more frequent users of that. Whereas with health insurance, if you tend to be healthy most of the time, you're going to tend to think, oh well, that's a waste of money. But that again. And this is something it would take too long to bring up this graph, but there's, to me, the most important graph. This was put out by KFF, which is like one of the largest, most respected nonpartisan healthcare think tanks.
Is that the Kaiser Foundation?
Well, it used to be called the Kaiser Family Foundation. It is
Gotcha.
now, but it's called KFF.
Okay.
They changed
I
the
was
name
just curious.
because
Same people,
they were
right?
Okay.
well, they are not associated with Kaiser Permanente, the big insurance company, but everybody always thought they were.
Confusing.
Yes, people
Oh,
for
I
years
see.
people have thought that they
Spelled
were.
the same. It's
Yes, and so people thought that they were associated with them, and so they're that seems kind of slanted because it's coming from.
Yeah.
So they changed their name to KFF. So
Okay, gotcha.
Yeah.
Well,
That's a
thanks for
good
that
idea.
clarification.
Yeah,
I
no,
appreciate that.
yeah,
yeah, because it
it's-
sure sounds like the same.
Right. No, so KFF, so they have a great bar graph which shows the breakout of total healthcare spending and how it breaks out by chunks of the population. And this is something that changes from year to year. It goes up or down a little bit here and there, but it's been remarkably consistent for decades, which is, generally speaking, roughly 5% of any large population.
Right.
I don't think this is limited to the United States. I think this would be true like anywhere around the world. Of any large population, roughly 5% of the population eats up around 50% of all healthcare services. Okay.
5% uses or eats up about 50%.
Yes. And like 10% eats up around 2/3, around 67%. So what you end up with is half of the population uses up like 97% of all healthcare services,
Sure.
and then the other half of the population only uses about 3%.
Right.
And again, this varies a little bit here and there, but it's very, very consistent. So what that means, and so on any given day, only on any given day, half the population is not going to be requiring any sort of healthcare. They're not going to be going to the doctor. They're not going to be sick. They're not whatever, nothing whatsoever. But the trick is the problem, and this is the whole point of health insurance, is that or any type of insurance, is that you never know.
Of course.
And this is the problem that a lot of people think, well, because I'm healthy, I shouldn't pay. Well, that's like saying because I don't have children, I shouldn't pay school taxes.
Exactly.
Because my elderly parents died, I shouldn't be paying for Medicare.
Right.
Right.
Well, you're going to be 65 someday.
That's right.
If your kids are grown, well, they're going to have kids. Maybe they're going to have kids someday.
Right.
Again, it goes back to your whole point of this is what living in a society is about.
Exactly right. When you live in a community, you want to have low crime in that community. Well, then you better have good schools to start off with. And so, should you be paying into the school system even if you don't have kids? Absolutely, because again, you're part of the community. And all your tax money is going to make sure that you have a high-quality community in all of those different aspects. And there are many different aspects
well, I mean,
to
it
that.
should. That assumes that you're electing and hiring,
that's
public
the goal.
people.
That's the goal, right.
Right.
It makes no sense at all to just, on a day-to-day basis, to just pay for what you use that day. This is not pay as you go.
Exactly.
That's utterly untenable in even the midterm, not even just the long term, right? And I think when you explain this to people, it only takes about 5 minutes to really prove your point, and hopefully the light goes on for them. Hopefully, sometimes it doesn't. Sometimes it just doesn't.
Yeah, and again when it comes to healthcare, as I said, I'll show this graph to people over and over, and if you look at it, what it basically says is that, and this goes into the people say they call it the ACA, right? Now, even my site is called ACA Signups, which is the Affordable Care Act, right? Mm-hmm. But the full name of the law is the Patient Protection and Affordable Care Act. And it's that patient protection part. That's the part that it gets a little bit more in the weeds. And that's where like this particular graph comes into play, because you could easily say, if you said, I want to cut the cost. People always talk about how healthcare spending in the United States is twice as high as any other country, yada, 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 right?
Right.
And you say, well, if I want to cut down on the cost of health insurance or of the cost of healthcare spending in the United States by 2/3, there's actually a very easy way to do that. You know what it is?
What's that?
It's that you cut out that 10% of the population that eats up 2/3 of healthcare spending. Hey, well,
really?
just throw them under the bus.
Yeah. Terrible idea.
Now it's morally, ethically, legally, it's a terrible thing to do, but it would do it.
Eliminate that.
But here's the thing. Yeah, you would immediately cut down. Just throw 33 million people under the bus. Aside from being horrible and awful, there's one more. Even if you have no morality whatsoever, here's the problem with that. Someday that's going to be you in that 10%.
That's true.
Of course.
It's not a fixed thing. It's not I'm healthy today, I'm going to be healthy tomorrow, I'm going to be healthy till the day I die. No, on a long enough time scale, everybody ends up with a pre-existing condition.
Absolutely.
Absolutely. Sooner or later you're going to get hit by a bus, diabetes,
you have accidents,
cancer, what have
you.
you.
For sure, absolutely.
And suddenly you're in that 10%. and you're not going to want to be, thrown under the bus,
No.
right?
No, you become
So,
very interested in how things work.
yes, all of a sudden, hey, that's
Oh.
not fair. So yeah, I think that's the thing that people have to keep in mind on.
Now, when it comes to spending reasonable amounts of money, right? So I don't like the term cutting costs. I like the approach and the syntax of figure out what you need, figure out what kind of doctors, nurses, radiologists, all these healthcare providers, many of them, right? For a given population, for a given demographic, right? Okay, how much is that going to cost? Given reasonable salaries, okay, reasonable compensation, and we can come up as a society, we can come up with reasonable compensation.
Yeah.
Okay, maybe something in the range of, annually $200,000 to $300,000 for highly qualified people, not $1 million a year. Okay, that could be looked at as excessive. Okay, and we can use other countries as some baselines for that. And then once you know your expenses, then you can regulate costs, you can cap costs, and people should be paid, a reasonable amount of money. You pay the providers, and so now you've right-sized your providers, and basically see how that goes. And then, let's be honest, continuous improvement is just that. Okay, no matter where you're at, no matter what kind
Always.
of process or people or resources you put in place, you always want to be looking for how can I improve from where I'm at. So that's continuous improvement. Okay, so that's always going on in every industry, but that's not the same as solving systemic problems. When you have deep-rooted systemic problems or price gouging that's obvious, that's not continuous improvement. You have to go at that with a significant task force and get that out of the way so that you can get to the point where you don't have obvious systemic problems, and you can get to the point where you're doing just continuous improvement, because that's all you really need to do.
Yeah, and the sort of the I'm going to play. I'm not playing devil's advocate here exactly.
No, go right ahead. That's all right.
But here's the issue with a couple things. So first, so the insurance industry, the health insurance industry, of course, obviously it has been guilty of a long list of sins. Okay, a long list,
Absolutely.
and much public ire, and most of it is well deserved. Having said that, and I'm not trying to act as an apologist for him, but just this isn't an apology for it. This is in addition to. In addition to that, however, it's also important to keep in mind what you just touched on, which is that the insurance industry, the premiums and co-pays and deductibles and all that stuff,
Right.
what is that based on? Now, some of that is, obviously price gouging and, and greed and all that. There's a lot of that too. But at the core of it, it's based on the provider cost. That is, how much is the hospitals, the doctors, the pharmaceutical companies, the drugs, what is it paying for?
It's based in part on
Right.
that. Yes,
It's
it
based
is.
on
Yeah.
that. So, and one thing that I've noted, and I say this as someone like my father was a doctor.
Wow.
I'm
That's incredible.
is that I've noticed that the public ire the major players in the healthcare industry in the U.S. You've got the insurance, you've got pharma, the drug companies, you've got the medical, the AMA, like the doctors, you've got the hospital industry,
Yeah.
Sure.
and then you've got like medical device makers and that sort
Yeah.
of thing.
Well, sure.
I'd say those
Nurses
are,
unions. You have a lot of different
right.
organizations.
So you've
that
got probably
represent them.
a half dozen, right? Of those, I've noticed something like 95% of the public anger focuses on two of those: insurance.
Okay.
And pharma, and the drug companies.
Yeah.
Insurance
right?
providers and big pharma. Yeah.
Well, the drug providers specifically.
Okay.
Hospitals, doctors, nurses, the actual healthcare providers, they seem to not get too much of it. I mean, in specific cases they do,
Okay.
but sort of big picture on the whole, they tend to sort of, and I can understand that partially. And again, I'm not bashing on doctors or nurses.
Sure.
They do wonderful work. But I think part of it is because when you're sick or injured and you go to the hospital, if the hospital is overcharging you, at least you can see what it's being overcharged for. $50 for a Tylenol. At least you're getting a Tylenol. Like you can. There's something tangible
It's
there.
tangible.
The
Yeah.
tangible-
There's people.
tangible
there's
health
a
is
face.
right there.
There's a doctor. There's a nurse. You can see the equipment.
Yeah.
All
Yeah.
that $1 million
They're using
machinery.
it on you.
You see the stuff.
Yeah.
You feel the stuff. You hear the machine that goes ping.
Yeah.
All that. Whereas with the drug companies and especially the insurance companies, it's
even.
this amorphous. It's just this vague.
They're faceless.
It's this faceless corporation 1,000 miles away that you're just dealing with. With 7 different. A bunch of emails and paperwork and stuff, and you're like, well, what are they? They're not performing surgery. They're not injecting medication. Mm-hmm. They're just saying, "Give us money." That's what it feels like. That's what it could feel like. And so I think that that's an important thing to keep in mind is that if you have, you said a reasonable compensation, and you said,
right.
well, $200,000 or $300,000 for. Now, here's the thing. Let's say that if you're a young doctor just fresh out of medical school,
right?
$300,000 a year, that's a lot of money. But at the same number one, what if you've racked up $300,000 in student debt to pay for medical school?
Very true, and that could be another discussion we could have.
Which is a whole other discussion, right?
Because it shouldn't be that high. It absolutely shouldn't be anywhere near that high.
And that's the thing is when we talk about comparing to other countries,
right?
Well, what do other countries? How is their education paid for? Or their higher education,
sure,
right?
It's not like ours.
So that's another
absolutely
factor
right,
to keep in mind.
Absolutely right.
And the other side of that is, let's say that you have a neurosurgeon, some
very
specialized, surgeon or whatever, been doing this for 20 years, and they're making and they're a millionaire, and they're making a couple $1,000,000 a year, and you tell them, well, that's too much. You're going to go down to $300,000.
Right.
From their perspective, rightly or wrongly, from their perspective, I mean, I don't know what either of you do for a living, but would somebody says, well, you should take a 75% pay cut because you're being paid too much. Even if you are.
So I would be okay with that if it was down from $1 million down to 300.
You might be, but they're probably not.
Well, so that's fine, and so
this is the discussion. This is the
sure. So, I think that it makes a lot of sense that if when we go to a single payer system, that this idea of cost regulation, because we're just talking about expense regulation, okay, you have to look at all the places where the expenses are happening,
right?
Okay, all of them, and there are many of them. The payer, okay, the service provider, many of them, right? The hospital, and there are people in between. There are the the suppliers for all of the instrumentation and so forth, right? All of that kind of stuff, all different kind of service providers. You have to honestly look at all of that, and at least we have to do our best to prevent excessive pricing in all those areas. Okay, so I think if that's our
absolutely.
So that's our motivation.
Right.
Let's at least make let's do our due diligence, okay, to do that. And as a first swipe, let's see where we turn out. Let's see what happens. And then again, then you can get closer to this continuous improvement. And I'm perfectly fine with some people being really upset of not making $1 million a year. I'll fight that battle all day long.
And that's
right? It's fine. Go ahead.
That's the
speak
thing
up about that.
And I've written a couple pieces about this, about how again, I'm not when I say these things, I'm not saying this as an argument for not doing X, Y, Z. I'm just saying that there are some people who you just have to understand what you're up against. Like if the AMA comes out against something. Well, why is that? But there's also something that's just occurred to me while we were just talking about this, which is. So I have a relative who is currently they're in the hospital right now over at I think it's Henry Ford out in West Bloomfield.
Okay.
And this is not I'm not ripping on Henry Ford healthcare systems or anything. This is not. I'm just using it as an example. Okay. I don't know if you've either been to that facility. It's gorgeous. It's wide hallways and atriums, and they've got they've got like a fountain or something.
Okay.
And they have like it's called like they have street names for the different hallways and stuff.
And so
it's
your
very,
point
very
point is what?
The point my point is, and that's wonderful, except that here's the question:
is it?
This is a hospital. Now I'm not saying that a hospital should be skimping and scraping and should be a tiny little hovel or anything, but how much of the money is going towards these ridiculously elaborate medical centers?
Sure. How nice should it be?
Right, exactly.
That's exactly what you're saying.
I want the staff, the doctors and nurses and orderlies. I want them to be well skilled and well trained. I want them to have proper equipment.
Yes.
Because that's what counts when it comes to your care.
Right.
And
But
my care, that's what counts.
But
It's
I'm
not the
not
Four
there-
Seasons, baby.
I'm not going there to go on a cruise.
No,
This
right.
isn't a Carnival
It's
cruise
not
line.
sandals.
Exactly.
Sandals.
Exactly.
No, it's not.
So-
and it shouldn't look like that. Okay? Because this is the impression when you walk in, and that could give the wrong impression. And so, again, cost monitoring and cost optimization and quality optimization has to be looked at all levels. And so that right there is a great point. When you come in, when I or any of us walk into a hospital, it should be clean, it should be functional, it should take care of us, right? It has to handle the load of people. The emergency room has to be laid out and architected in such a way to handle
Right.
that kind of thing. It's primarily functional. Let's just be honest. It's primarily functional, right? So once you accomplish those items, I'm a software architect right? So I always think of function first.
Yeah.
How does it work?
Right.
How does it work? And how do the people interact with each other? How do teams and people work? Right? Once you accomplish that, and the people are happy working there, and the patients that come in are happy, you've met your. I don't care what color the wall is. Okay.
Yeah.
So, but again, we know how to address these kind of things. We do.
Yes.
And so we can put knowledgeable people in charge of how do you appropriately build the new Henry Ford Hospital in Bloomfield. Okay, if the old one is too old and doesn't meet the purposes, what should the new one look like? Okay, within a reasonable budget.
Right.
Okay, because I much rather have more MRI machines than to have street signs in the hallways.
Well, and that's funny that you say that, because the other thing and this is sort of switching back to the whole 5%, or 10%, utilization thing.
Yeah.
One thing when it comes to, I mentioned before that the people who are uninsured and they have, they basically just have emergency room care. One of the reasons why programs like Medicare, Medicaid, and the ACA are so important is that if someone is uninsured and they get hit by a car, or they have a heart attack, or whatever, and they're rushed to the emergency room.
Yeah.
There's always going to be some emergency room. That's what it's there for. But when you have people coming in, for something that isn't something that if they had insurance or they had, some sort of coverage, that they would have gone into a doctor 6 weeks earlier for.
Right.
And it might have cost a couple $100 to treat.
Right.
And instead, they wait until, because they can't afford that, they don't have insurance, so they wait until they absolutely have to, and now they're at death's door and they're crawling into the emergency room. And now it's going to cost $1 million, to save their life or whatever. Emergency room care is insanely expensive, and a big part of the reason for that is because it's the emergency room. They have to have all that multi-million-dollar equipment,
Right.
not just there, but on with staff, with staffers who know how to operate
Ready to go right now.
Trained staffers
Yeah.
that have to
Yeah.
be ready 24/7, right? They have to be ready to deal with whatever the emergency is at any
Right.
time. So all that pricey equipment is sitting there all the time. And they, and so the less you have to utilize it, you can save a lot. You can save a lot of expenses by having someone who's, again, gets preventative care today versus having emergency room care, next month.
Absolutely. So I think education goes a long way to that. People have to know that first of all, they have to be able to go to their doctor and not have to shell out $300 just for a doctor's visit because they can't afford $300, but they can afford 50, or they can afford 25. Okay, and so that's partly education, and it's partly the mindset of the American citizen, I think. And so we have to fix so many things in order to get to that level where more people are taking the preventative care seriously, and then you're going to definitely see the emergency room visits be, let's just say, much more appropriate, right? That's the goal, right? And I think I know we can do that if we are intentional about it and we want to do it. The problem is we've never wanted to do it. Our representatives have never wanted to do that, and they still don't want to do that.
Sorry, I think we went off on a bit of a rant there.
Bit of a tangent?
Yeah.
That was a fun tangent.
That was a good because we're always so interested in affordable for everyone, right? Like not just
Well, yeah.
Medicare for all.
Affordable for everyone. So, sure, that's actually, I think of that as a bit of a misnomer. Every citizen, I just use the term, citizen, right? Again, born here, cradle to grave, just like you get a social security card number, right? When you're born in the hospital, wherever you happen to get that. When you're born at the hospital, here's your Medicare. Let's just call it Medicare. Here's your Medicare card. Here's your unique ID. Bingo, you're covered. You're covered, right? And so, right, and you're covered for basically everything. Now, when I say everything, maybe certain cosmetic procedures that are fully elective that we can all agree to that you may not need. Okay, if you want to pay for that out of pocket, I don't think many people will have a problem with that. I think they'd be okay. But all cancer, right? All oncology, diabetes, everything else. All these serious diseases, even not so serious ones that all of us go through from time to time, should be absolutely completely covered, so that they don't bankrupt you when you have to go for that kind of treatment.
Well, see, now here's where I'm actually going to. I actually am going to play devil's advocate a little bit, sort of.
Disagree, please do.
Well, sort of more to the side than opposing, I'd say, but which is things to keep in mind. So that the donut graph that we had up earlier with all the different color coding. The thing to note about that is that it's not so much that the United States doesn't have a quote unquote universal healthcare system, so much as that we have all of them at once overlapping with each other. It's an incredibly inefficient. We have a patchwork of systems which kind of sort of work. They work as they do. Yeah, to some degree. There are other systems, I know you're a big single payer advocate. There are other systems as well, like the German system, which is actually, the German system, as I understand it, is more like if it was an employer-based system, except that the insurance companies were not for profit, basically much more heavily regulated, and that there was an alternate system for people who did not have employer coverage, right? But the point is that everybody's through. It's one system. It's not this patchwork. The Swiss system, Switzerland, their system, as I understand it, is more like the ACA for all. That is, individual that you sign up with individual. You're not through your employer. You sign up. Everybody signs up for individual market coverage, except that again, not for profit, or at least minimal profits. Much more strictly regulated.
Gotcha.
So it'd be like if if all 340 million of us were insured through healthcare.gov with the government, the generous federal subsidies, but the insurance companies themselves were basically nonprofit or not for profit.
Gotcha. Yeah.
Any of these, and there's a bunch of other systems as well, different variants. Any of these systems would probably be fine and better than what we have now, because what we have now is we get a mishmash of each of these, and they're competing with each other.
Tremendously better.
The VA, the Veterans Administration, is actually essentially socialized medicine, like they have in the United Kingdom.
Sure.
Because it's not just single. It's not just that it's single payer. It's because the government also employs that the providers work for the government as well through the military.
Right.
Doctors, nurses, and hospitals and such are through the government. So we have all of it. It's just it's thrown into a blender, and so there's a lot of people who fall through the cracks, and there's a lot of inefficiencies, a lot of overlapping, et cetera, et cetera. So the more that I've learned about this, two things have become increasingly true for me over the past decade. The more I look at that psychedelic donut, as I call it, the more I believe that we need to have fewer slices, that is, fewer larger slices instead of more tinier slices. But at the same time, the more difficult I think it's going to be to achieve that. It's like it fights against itself.
And why? Specifically, why is that difficult, do you
because
think?
Every one of those players, right? All those different, the insurance company lobby, the hospital lobby, the medical lobby, the pharmaceutical lobby, as well as all the companies that manage and administer within that, all the second
Right.
tier and third tier, each of them has their own agenda, right? Nobody wants their bowl taken away.
Right.
They've got their little. Their little
Piece of the pie. Yeah.
and they don't want their
They
piece
don't
of the
want
pie
it.
taken away, right? Because if you take it from here, in fact, I mean, like the small business, the small group market for small businesses, that's been gradually shrinking for the past. Actually, I mean, before the ACA, it's been shrinking a bit every year for the past decade or two. Well, small group insurance companies, they're getting nervous. They're not happy about that. The reason it's because more people are moving towards ACA individual market.
Right.
But the other thing about that is that when people talk about, again, private versus public, did you know that over half of Medicare is now privately administered?
Wow.
Medicare Advantage, which is the privately administered version of Medicare, for good or for bad, I'm not a fan, but over the past year, it nudged over the 50% mark.
So there's more people on
there are now
Medicare
more
Advantage
people
than
enrolled in Medicare
original.
Advantage plans than in traditional fee-for-service Medicaid.
Sure,
Medicare.
I'm not surprised at all because there's money involved. And,
So much advertising
and
money.
it's a
Oh
money
my
grab for those
God.
And
providers.
Medicaid,
Yeah.
Medicaid, which covers around 73 million Americans, Medicaid is about 80% privately administered because
Sure.
it's administered by the states, but most of the states have basically said, "Oh, it's too much of a headache for us. We're going to outsource it and have a private insurance company."
That's ridiculous.
What's the insurance? It's the same insurance companies
the
in a
same
lot of
company.
cases are
It's the same.
administering both.
Right.
All of these different types.
Right.
In fact, I could be wrong about this, but I believe that most health insurance revenue, I believe, comes through public programs now, not through, quote unquote private, because basically MCOs, managed care organizations, which is basically Medicaid Advantage essentially.
Okay.
It's, privately around 80% of Medicaid is privately administered through insurance companies. Around 50% of Medicare. Obviously, the ACA, the 24 million or so on ACA plans, those are all private directly through
Insurance companies, right?
private insurance companies, right? And then of course the employer coverage. So it's it's not really private versus public. It's a mishmash. They're embedded into each other.
Sure, we've had that for some time.
And again, whether that's good or bad, you can certainly argue, but that's what the situation is. So unraveling that thread,
Yeah.
trying to merge all these pieces into larger chunks.
And no one wants to give up what they've achieved. Like
Exactly.
no one wants to give up that ground.
Like I said, if you make $1 million a year, even if you quote unquote should only be making 200,
Right.
200, 300,000,
A more reasonable salary, right?
most people are not going to willingly give that up, even if they quote unquote should.
Well,
So-
sure, and this is where, and let me just maybe put a finer point on that, where we the people have to stand up and say this is the way it's going to be because our communities suffer greatly when we have the wealth inequality. So we the people, the average person, who fully agrees that we should have full coverage.
Yes.
I don't care. I don't give a damn if the ultra wealthy are going to cry. I'll get my cup and I'll catch your tears and I'll drink them happily every day of the year. I don't give a damn, right? Those people are going to lose.
Yeah.
But guess what? If they go down from $1 million down to 300,000, they're going to get by just fine.
Somehow.
Just fine, right? So I don't. So the of course you won't make everybody happy, but that's actually a good thing because they shouldn't be happy about that. And then when it comes to the private insurance companies, the for-profit ones, okay, that's exactly what they are. They're in it to take as much of our money as possible and to provide as little as possible, deny care as often as possible, and they work very hard at denying us coverage. That's their number one goal, to deny that, and that's absolutely immoral. And so we, the people, acting as representatives, should absolutely go after that. And let's just be honest, squash that. So no, you're not going to get away with it anymore. This is where the power of economy of scale and single payer, I think, really comes in. So, is it going to be difficult? Of course,
Absolutely.
Of course, it will be.
Oh my God.
Whenever you go after the rich, they're going to come after you full force. But we do have the numbers. They may have, in some cases, more of the money, and they've bribed a lot of our representatives, most of them, nearly all of them. So is it an uphill battle? Absolutely. Do we have to fight the battle? 100% we have to fight the battle because we're dying in the streets because of it.
Yeah, we can't afford not to.
Well, we can't. We can't because what we have is absolutely embarrassing. We're the laughing stock of the world when people look at what we have.
Now, I will throw in one final. I don't know if we have time.
Yeah, no, we're doing fine. We have
Okay.
It's no problem.
Okay.
Yeah.
We have to wrote down have a hard stop.
Yeah, no.
Okay.
No, it's not really.
The other thing that I was going to say is that I'm going to throw again, and here I am here again, sort of a devil's advocate kind of thing. Here I am going to throw in one monkey wrench into the gears regarding the argument in favor of full universal. Call it what you will call it.
Sure, single
payer.
payer.
Call it Medicare for all. Call it what have you. Which is this: Robert F. Kennedy Jr. We talked about a little bit before the show. I don't know how many of your viewers or listeners saw his Senate confirmation hearings. I don't know whether he's going to, confirmed or not. I hope to God he isn't, but let's be honest, the odds are he probably will.
Probably.
Likely, and even if he isn't, it's going to be probably somebody almost as bad. But if you watch the conversation, he literally does not know the difference between Medicare and Medicaid. He literally does not, he did not know the basics of anything. And this is the person, now here's again, this is the catch-22 of a single payer, of any sort of universal one system for all, whether it's, single payer or one of these other systems,
right.
is if you put all your eggs in one basket, literally, then you better make damn sure that the person in charge of that basket, A, knows what they're doing,
of course,
and B,
of course,
and B, has good intentions.
Right.
Absolutely, Charles.
There are people that President Trump could nominate who actually do understand, who are qualified in the sense of understanding the healthcare system and how insurance works.
Those folks are out there,
right? Who know all this stuff. That doesn't mean that they have good, that they're a good player. And so the concern that a lot of people tend to have is that, do you want RFK Jr. to be in charge of everything having to do with the U.S. healthcare system?
No, of course not.
He may be about to be in charge of a big chunk of it.
Yeah.
But people tend to get nervous about allowing every decision about what's allowed, what isn't allowed, what would be approved, what wouldn't be approved, what would be covered, what wouldn't be covered.
Right.
Now, right now, we have the fear that people have is right now you talk about denials, denied coverage.
Right. Denial of
right now,
service,
you've got a bunch of nameless, faceless bureaucrats at private insurance companies making those decisions. Right.
Arguably, right.
Is it better or worse to have one political appointee making those decisions ultimately, or a panel of appointees or what have you?
Yeah,
you could argue that either way. It sucks either way if they're making bad decisions.
That's the point. So look, in every organization on this earth is a group of people, whether they're government, public sector, private sector.
Right.
An organization, by definition, is not a group of ducks.
Right.
Okay? It's not a group of dogs, a group of people.
Right.
Just like us, right? And so, at any level, if you want any particular group to work reasonably well, it starts with leadership. You have to have competent, well-educated, basically properly motivated, leadership. You have to. If you don't have that, then that group is destined to fail, or they will accomplish precious little. Okay, that's always the case. So, whatever improvements I'm talking about or changes in direction really presumes quality leadership.
Right.
You always have to have quality leadership in the home, right? At the police force, right? At the hospital, at the local drugstore. If you don't have quality leadership, then you're dead in the water, right? And so, how do you fix that? Well, you fire the leadership and you get better leadership because it is possible. We've seen it. Good leadership is possible. Mm-hmm. Is it tough to get and maintain? Yeah, it's difficult, but it's absolutely possible.
Absolutely. Well, it'll be interesting to continue to comment on what things, are evolving and changing, right? And I'd love for us to have more discussions. I hope that you've enjoyed talking about,
Well,
this is really important.
Well, it's going to be an interesting. The next few years are definitely going to be interesting. Let's put it.
Yeah.
What's the old saying? The Chinese curse. May you live in interesting times. I believe. Is
Oh,
the,
yeah.
Is, you know. And,
Yeah, I'd rather live in uninteresting times, right?
Or
as
what's
they
the
say.
American? I think the American version of that is all things being equal, I'd rather be in Philadelphia. Apparently, the implications of apparently Philadelphia is
Okay.
supposed to be a dull town or something. I don't know.
Okay.
But
That's interesting.
I want, yes, but the generally, the larger point being, I want quiet competence,
Yeah.
not interesting.
We all want that.
Chaos.
I really
and,
want
100%. 100%.
And apparently 77 million people decided that they wanted incompetent chaos.
Well, that's 100% true, and so that's what we're seeing, and that's what we're getting. So none of us should be surprised, but at the same time, we have to continue to fight for better for proper health care.
Yeah, and we do have voices, and we're independent, and we can.
We have to
say-
find the leverage. That's the problem, is we don't have much leverage.
But there's more of us.
And let's hope.
I really am.
Yeah.
Very
Good
glad.
discussion. Thanks, Charles.
Thank
No,
you.
thank you for having
so
me.
much.
Appreciate it.
It was really so interesting. I love the that donut, like the distribution of how many people are in each kind of sector.
Yeah, very
That was
clear.
really-
It laid it out
was
very
really
clearly.
good.
Yeah, I mean, it's not precise because there's always a little fuzziness here and there, but I made it as close as I could.
I just
Well-
wish that there wasn't anyone, that didn't know how to get a plan, because if there's 5 million,
The white section
yeah,
in,
like
in,
5,
in,
10
in the
million,
donut, yeah.
it makes me sad that
Well,
they
yeah,
are
I mean,
completely don't have health care at all.
yeah, I mean, as I said, of that 26 or so million, like I said, or something like half of them are in theory, you could lop that in half through proper education and outreach and so forth. Basically getting all those people actually enrolled.
Right.
For the other half, a big chunk of unfortunately, a big chunk of that is undocumented immigrants.
Yes.
And of
Sure.
course, you want to talk about hot button issues, especially right now.
Different issue, different argument.
That's a
yeah.
whole, other thing.
Right. Right.
And even to the point, I mentioned like stigma, Medicaid and such. They're like in California, for example, federal funds, federal subsidies cannot, will not be, do not pay for undocumented immigrants to
Right.
have healthcare coverage, right?
Right.
But there are some states, including like California, Washington State, Colorado, where they actually have, like California actually has several 100,000 undocumented immigrants on Medicaid. It's just that
State-based program.
Right. It's just that the state is covering, instead of the feds covering most of it,
Gotcha.
the state's covering all of it. It's all
Gotcha.
state funds. Well, the thing is, especially right now, there are a lot of undocumented immigrants who the government is the state government is reassuring them that your data is safe. We're not going to report who you are. But I'm sorry, if I was an undocumented immigrant
they don't
right
believe
now,
it.
there's no way in hell that I would be,
Yeah, going
so
to-
it's understandable. The
going to
fear,
a hospital, yeah.
Right, the fear
Yeah.
is very strong.
Yeah.
And that's sad.
Yeah, it makes sense.
It's sad.
It makes
but
sense.
It is.
Another problem, yeah, the whole immigration thing.
Yeah,
All
if you
right.
want to come back with some slides and things like that we can talk about,
Sure,
different things
yeah,
that you'd
yeah.
like to highlight. I think it's a great discussion, and really, it's been such a pleasure truly to talk with both of you. Thank you so much for your time.
Oh,
Thanks
thank
for
you.
watching. You're
Yeah.
so welcome. Thank you for watching, and we'll follow up because we have more to talk about. Thank you.
We're out.
We're off mic, right?